pass on to Patty Musolino, and she's going to present on some of their outreach work in South America.
Thank you, Keith. Again, thank you for the invitation to speak and share this experience. This is work that has come to us. We didn't go look for it. And I feel pretty ashamed of what I'm going to show after our colleague from Korea showing us what you've been able to do in 1 year and not coming from the same discipline. I'm still very, very humbled. Okay, I have it here.
Do you have a thumb drive?
Yeah, I have a thumb drive. Let me just. She doesn't have it. It's called ALD Connect in Latin America. So I can maybe entertain. So basically what I'm going to show you is a mix of a lot of little experiences of things and tools that we've been using, and a lot of this has just to do with the fact that I was born in Buenos Aires, raised, studied there. I did not do clinical training in Buenos Aires, so I don't know all the colleagues in the field of neurology, for example. But because of the language, I think, familiarity, and also because of the network that people already have because of the needs that they have, it was very expansive very quickly. And this is what has the latest developments. I think Florian introduced something of this at the beginning, is that we were invited to go down and talk in their national neurology meeting, and around that meeting there were a LUCO board organized around the metabolic, genetic, and child neurologist in Buenos Aires, but for people around the country. And there was also a family meeting of patients with leukodystrophies. So I'm going to show you a little bit of that experience. So those are financial disclosures. Basically, it's mainly NIH and foundation funding, which I want to emphasize also the contribution of the advocacy groups on the research that we do. I'm working with Dr. Eichler at the MGH Center for Rare Neurological Disorders. This is now housed in the CHER, the Center for Human Genetic Research at MGH. As this is something that this audience knows very well, so I'm going to pretty much skip. But the points that I wanted to make on this is, for most patients in Latin America, this phenotype exists, but it's not diagnosed, and it doesn't have a name. So neither men nor women talk about AMN. This is acknowledged, exists, is suffered. And the adrenal insufficiency is another one that only these patients have the luxury of being treated for and diagnosed. There are centers that have the capability of doing the entire care, but there's very little training on the clinician side to provide the appropriate care. So I wanted to say something. They were talking about newborn screening, so I have all these talks, and being the last one on the day helps a lot. Thanks to the collaboration with Ann Moser, who was a paramount contributor to the fact that we can do newborn screening from dry blood. She is testing for free patients from Latin America as far as they have a clinician that will help them interpret the results and take over from there. So this has been very helpful, because from one patient you can see what a pedigree usually looks like, and this is not surprising. And this is now made available, at least for the males, thanks to the sharing of Ann Moser's expertise. So natural history, I think everybody talked. This is cerebral ALD natural history. We have normal boys. We get a lesion in the brain. The contrast comes in, and the lesion progresses very rapidly. And then we lose a lot of ground by the time the patient gets the symptoms. And we do have a window for treatment. This is mostly applicable to developed countries where bone marrow transplant is done in good conditions and the outcomes are good. And then you can potentially arrest the cerebral disease. And I think you also have heard the difficulties and the challenges of doing bone marrow transplant on these children or adults. That's basically the natural history in Latin America. There is a window for treatment. These patients might even be getting screenings, and we're getting their MRIs. But once they're diagnosed, there is centers that don't want to do bone marrow transplant in these metabolic disorders because the experience has been that they all die. So that's a reality. In most developing countries, bone marrow transplant is not a possibility. And of course, for AMN, it will be great to acknowledge that the disease exists in first place, to be able to talk about treatments and accessing any kind of healthcare. So I take this from one of the latest publications, and you can see that the incidence of ALD, and we know these numbers are changing very quickly, but I wanted to point out that there is only, in all the reported studies, only one comes from developing countries. And this comes only from one hospital, as you can see. So is it a rare disease? And I remember a patient of Florian's, a mother that says rare diseases remain rare as far as we don't diagnose them. So this is what happened after Florian started the ALD 102 Sterabine Bluebird Bio gene therapy trial. Once we had a therapy to be offered, we were contacted by these people in 2 years, 118 patients screened with cerebral ALD from all these countries to see if we could offer, if they could enroll in this trial. And I'm just pointing out this was 18 months to get 118 patients. So it is rare, but as soon as you get something to be offered to the patients, I think the disease becomes less rare. And this is not even including that most of this, well, I'm gonna leave Australia out, most of this part of the world doesn't even diagnose the disease. How do we do these evaluations with people around the world? And this was permitted thanks to the fact that I work in critical care neurology and stroke, and so I use a platform for delivering acute treatments to patients with a stroke that is called Telestroke Telehealth. They lend me the platform, they gave me all the rights, they gave me the MRI, and they gave me the coordinators, the IT support to do global teleneurology, which means for free. There are legal considerations that I also have to talk to people. I need a physician on the other side that takes responsibility for the clinical care of the patient. And I think it's paramount that we have the clinician on the other side, because you don't want to talk to a family and just leave them with, this is what you need to do, and they don't know where they're going to get it. So all the video conferences take some time to be coordinated, but we try to do it. And the clinician doesn't need to be a child neurologist. In fact, they're very rare. So I have had conferences with adult clinicians, like medical medicine, general medicine, geneticists. I have had consults with nurses in the room that were the ones that helped the patient get to the clinics. I have not had consults in the hospital with other hospitals, by the way. So we also been using telehealth in a basically global health effort with some other NGOs to provide clinical care to areas that are underserved in Latin America, and I'll show you an example. Education. We talked about this all day long, and this is incredibly necessary. And it's not only the family and the patient education, it's the physician and caregivers. From the fact that what does it look like in an MRI, the lesion? And I have had conversations even with the technicians in the MRIs to get the right sequences. Because if we don't get the right pictures, we cannot do the right diagnosis. And also to allow participation in research. These patients are eager to participate in research. And then training healthcare professionals like radiologists. So very early lesions are most commonly not even mentioned or diagnosed, at least if they are not in the typical spot. Even if the MRI is being done because the boy has adrenoleukodystrophy. These lesions will go underdiagnosed. So we want to catch them before they get to a more advanced dose. And then instruct them about treatments, so bone marrow therapy, gene therapy, and other treatments that are supportive care that is so paramount to improve the quality of life. So challenges of caring for rare diseases in Latin America, and this was led by a colleague that is working with us. So pretty large extension, tons of people, but the main problem is that they are very spread apart. They're not concentrated in urban cities areas. There are very few countries that have large cities like Brazil or Argentina and Mexico. The other ones are very sparse populations. So accessing these patients, again, is not bringing them to the center necessarily, it's getting to the patients to, in first place, get tested and diagnosed. There are very basic needs that are met in some of these areas, not in all of them. And there are very heterogeneous reimbursement policies. And this is access to care, basically. It's very unequal and unfair, which I don't think is different from the US in a way. So different, yeah, there was a little note. So different settings, same suffering, and urge for treatments. And I truly believe on this thing. I don't think because you're born in America or in the Netherlands or anywhere where you have all the best doctors in the world and the healthcare, and you're born in front of the children's hospital, that you suffer less of the disease, that you're born in a place where you don't even have water. And I think that's human nature. When you adapt and you work and you get through, and when it hits you, you suffer and it's painful. And the urge for treatments, I want to accent that part as well. They want to hear that there is someone thinking and working for them, that there's going to happen something with this disease. And this is because it's a disease that affects generations. So even if I lost a child or a brother, I do want to see a difference made to my cousin, my nephew, my grandchildren. So they are engaged even when the disease has passed already their own nuclear family. So I'm going to show you one of those experiences of providing global health is through volunteering with Compañeros en Salud, which is Partners in Health, Paul Farmer, Boston-based NGO, large healthcare nonprofit organization. And this is in Chiapas, is in the border with Guatemala. We are strictly in the border with Guatemala. We're a little bit far away from the Zapatistas, which are a guerrilla that you don't want to get in trouble with. They usually cut the roads, so we need to talk to them when we need to get a patient to the hospital because we need the road open. But they pretty much let us work and allow these clinics to work. This is not updated data. These are now 12 clinics, not 6 clinics, and they are in the mountains, in the top of the mountains. They're very small, but anything here requires a 4x4. This is 2.5 hours, 45 minutes, 1.5 hours, 2 hours from the next town, which is not a city, and it doesn't have a hospital. So we're talking about primary care with the first level 1 hospital 2 hours away in a 4x4, which is unaffordable for the people that lives there. So this is how the clinics look like. And there is a physician deployed by this NGO that has help from a nurse that is assigned by the government. Mexico is not a poor country. They have a healthcare system. The problem is these people are out of the healthcare system. So what the NGO mainly does is bring them in. So these people exist. They have diabetes. They have hypertension. They have problems. We need the medications. We need to provide care to them. This is just to show you the roads. Sometimes very scary, so mostly in the rainy season. This is tropical weather. And this is what happens sometimes. This is coffee drying out, that you cannot go through the road because it's drying coffee. And this is what yeah, don't step on the coffee because that's going to be bad. And this is what a community looks like. And again, you need to get out and take a look at what people are dealing with to adjust your guidelines. And I invite anything that is proposed for the newborn screening and ALD Connect to be customized to each area, because each part of the country, each area has different capacities and different needs and different tools and resources. It went away. Hopefully, is it coming up? That's the one that I didn't want to open, but it's doing it. Okay, I'll get to it hopefully quickly. Doesn't let me out. So these are the patients, and you can do a lot of neurology. Remember that the brain, it's interrogated by the exam. It's one of the few organs that you don't need a lab test or an imaging test. And there is a lot of things that are affecting people that can be treated, and there are resources to do those treatments. So how do you follow these patients? I have 160 patients in this area, in 12,000 people community, diagnosed with treatments, and we follow them remotely. So there is once a month, they get together, the physicians, the general practitioners get together in a small town. We video conference and we run the patient's list. And it's like, how is it doing? Do we need to adjust the medications? Do we need to change? Does the patient needs to get out to do a test? There are other countries that have even registries about these patients. And this is Argentina. This is the country I was born in. And this is, for example, the data they have collected from the laboratory that does the very long-chain fatty acid testing, which is the Chamoles laboratory. And this is their incidence, which is pretty similar to what you were showing about Korean experience. We still have a lot of patients that are without diagnosis, and there are very, very few that are pre-symptomatic in this cohort. The people that has been involved in doing diagnosis for ALD are very engaged in neurometabolics and leukodystrophies. They do have expertise in the neuroradiology side, in the biochemical side, and in the neurology and endocrinology side. So this year, over the last 2 years, they've been trying to put together a workshop, basically, and what they call it their LUCO board. And what they're trying to bring through the Infantile Neurology Society is a patient advocate foundation that has pushed these people to really get together and start talking and working together. Is basically putting a local board. And as you can see, they already have 12 hospitals across the country participating, and they have the proposal of doing this every 2 months, virtual meetings. They have imaging and laboratory, electronic shared platform, and they are setting up to interact with international networks, including us if we are open to connect. This is the family meeting that was done as a satellite activity, also supported in part by Bluebird Bio, who gave a fund to the foundation to allow these families to travel and get together. And this is Florian speaking Spanish, which it's always great to have surprises. It's like he never learned Spanish in any school. He just traveled Latin America for a couple of years when he was young, and he speaks Spanish, and he understands the questions. I was like, humbling. I wish I can do the same with German. So patients want to participate. We have translated the ALD Connect to Spanish. It hasn't yet been uploaded, and we need to talk about it. But they want to participate in the patient portal. They want to use the webinars that are in ALD Connect and the explanations of how the genetic disorder functions. And this is all in English. Most of these people do not have the fluency to do it in English. So we really can access a lot of people by just making what we already have in the website available in Spanish. And what do we gain in connecting with Latin America? And these are my thoughts, but then I want to open up and you can tell me what do you think. As a patient and as a community of people caring for ALD, I truly believe that for every new leukodystrophy center or group of people that works with leukodystrophies in a coordinated fashion, there's a different level of expertise and approaches that can be brought to help other patients. And we have experienced this with our collaborators in Europe and Australia. Patients in regions where transplant is not possible want to eagerly participate in clinical trials. So this is a bias when you design a clinical trial, because you don't want to do this. So you want to compete to the standard of care, or you want to have the patients have the choice to go for bone marrow transplant, which we know it works if it's in the early stages, or do the other experimental treatment. But the reality is these people cannot be offered bone marrow transplantation. They don't have the care for the post-transplant even available, mainly because of the regions where they live and the hospitals that they have access to. And just to mention how reality this is, how real this is that 1/3 of all ALD 102 sterabine trial came from developing countries. So they also are eager to participate in any kind of trials if the possibilities, the financial support is there to allow them to participate. There is more participation in databases. I believe will accelerate the knowledge of natural history that we all so much talk about and improve the power of our biomarkers, so much needed to design the clinical trials. And the communal strategies for better care of these patients can be translated to the local centers. And this is the strength that these people have. Most people, most patients that I know in the US have at most mom, dad, maybe an uncle, and if they're super lucky, parents around in the town. The rest of your family lives somewhere else, is hours away or a flight away. These people live in communities where they have at least 10, 20 members in their family 5 blocks away. So they have built ways of caring for their loved ones, which are, some of them are very ingenious and they're very useful, and it might be able to transplant back to countries like ours. And I also believe that being part of a larger and more inclusive caring world is important. So in summary, I think Latin America is ready to participate in ALD Connect. Regional LUCO boards are being now established in Argentina, Mexico, and Colombia, and they're becoming the reference for the region, not just for their country. We can help accelerate this process at a low cost if we bring them in with their contributions. They are willing to participate. So we don't have to do work for them. They have to be included and allowed to work with us. Online resources and education in ALD Connect, I believe, can save lives just by educating about carrier status and AMN. There is successful experience in conducting industry-sponsored clinical trials in these countries, despite all limitations. And I think that's another important point, that these patients can be part of the clinical trial to develop those treatments that can get back to many more patients. And I just wanted to thank, and I put this very old picture, but I do believe that the legacy of this kind of work comes from these two that you all know, Hugo and Ann Moser, which I think instructed everybody that work with them, in patients, advocacy groups, and scientists and clinicians, to spread the word, be collaborative, bring everybody to the table, and so most of important to be humble that there is many more things to be done. So I really want to thank everybody that makes this possible, and I wanted to hear ideas of what do you think about bringing Latin America to ALD Connect.
Patty. Yeah. Florian, how do you pronounce that thing in the corner? So Patty, tell us, I mean, no one objects to your conclusions and all these 2 last slides, right? So what do you need from us?
So I think the Spanish patient portal. What do I need? Spanish patient portal. The second thing is, how do we open Neurobank? They do have registries with some of these patients tested for mutation. There are not that many, but they do have a possibility of collecting natural history that we might be able to put in Neurobank. I don't know the restrictions for international data sharing. I haven't
Not on our part. So if they have no restrictions in having data on the US soil, and again, we have data that are not identifying patients, but we have dates. So it's so-called limited data set. So if they have no restrictions, and we work with European counterparts, we have in Eurobank and ALS 35 European sites, and they enter data with no problem from their IRBs. So that's why I have no problem taking this. Even more, well, my understanding is for Neurobank, right, because they're clinicians, most of them do understand English. But if needs to be, we can develop site-specific forms that will be the same forms, but will with Spanish names or whatever, Spanish words.
That will be great. The clinicians, I don't think they need it, but they might be, maybe not in Argentina, but yeah, you would expect that any clinician does have enough English for reading purposes.
Well, we can start with the main city in Latin America, right? So
Yeah.
Buenos
Yeah.
Aires.
It's not the main city. Sao Paulo is 20 times bigger. The other thing is patient portal, to make it in Spanish, to translate like correctly, as you were saying, the interpretation of what that scale means is culturally differently. But we have prime time. We have a lot of patients engaged from Mexico, Colombia that can help us do this in a very personalized fashion.
So do you have a counterpart of Justin in Argentina?
There's only one me, Florian, okay?
I can try to identify a Naaman, but there are very, 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 very few men diagnosed. And you were in the meeting, and they're teenagers because they're still following with their parents, and then they disappear in life. But what I do have is moms of boys and teenagers with ALD that are super engaged, and many of them do speak English fluently to interact.
We'll first need to finalize our homegrown version here, get it, locked in, and then we can start working on, translation efforts and globalized efforts and trying to expand it. But I think the first stage is to kind of get it, I guess we'll call it, our sort of relaunch, whether that's going to be in a couple months or, really to get it good.
Sounds perfect. Translating the resources, the educational resources, and some of the webinars to Spanish could open and increase the access to this information. The clinicians are very eager to send the patients to ALD Connect if they can read the information and they can benefit from that. That's another request. Another request is like more a lot of pressure for the clinician side. This telemedicine thing can be done as a bigger effort. So there are countries that are prime ready to do their own local board, and we've been there and we witnessed the expertise of the neuroradiologist, and I think they're completely capable of doing it with minimal consultation, basically. There are other countries that do really need an expert in the room. So if you ask me, it will be great to, as they get organized, because they're doing it already, to be able to be more than one center that hops into that teleconference and helps with input and what to do with that patient. They're trying to determine what patients need to get treated and where do they send them. And there are many questions that come out that an expert can answer very easily. So if other centers are willing to participate on this, I can start passing on like consults and video conferences and.
Yeah, thanks so much, Patty. I mean, it's very inspiring to see what, I guess, put in perspective the fact that we're trying to democratize access in the U.S. and that's, you can see, it's just the beginning of the process, of a much, much larger process here for democratizing, a real standard of care globally. It's a very long road ahead, and good fuel for the fire that keeps us going. So.